Have you ever had a debate with a friend about what kind of exercise is best? As somebody who enjoys running and being outdoors, I tend to prioritize doing cardiovascular training and learning about it. But this all started to change when I shared an office with Dr. Henry Lang, who was more familiar with the resistance training side of things. This led to a lot of conversations and ultimately the development of this research study, which we'll be presenting on today. We do not have any individual disclosures. We did receive financial support from the University of Mary Faculty Research Grant, and this study was approved by the University of Mary IRB. Obesity is a hot topic in American society, as well as an important conversation for us to have as clinical exercise physiologists. So one of the concerns that comes up for individuals that have obesity is its association with metabolic disruption. So many individuals are going to have different metabolic problems. Some will have type 2 diabetes. Those that do not, 70 to 80% of them are still going to have insulin resistance. And we know that diet and exercise training can improve this. So we have a tool, however, there's some drawbacks to the tool. First of all, not everybody wants to go this route. Maybe people don't like the cardio training that's required for weight loss, or they don't want to track their diet. Additionally, when you do these types of programs, we see reductions in lean tissue, reductions in resting energy expenditure. However, current guidelines really are currently focusing on that weight loss aspect and the using cardio training to achieve it. And our question here is that the only way? Which leads us to the purpose. The main goal of this study was to explore the effects of a 10-week cardiovascular only compared to combined cardiovascular and resistance training on various measures of metabolic health, not just weight loss, as well as health-related quality of life among people with obesity. Started by recruiting individuals with obesity from the Bismarck-Mandan area. So to be included, an individual had to have a BMI between 30 and 40, be between the ages of 18 and 55, not smoke, and also be able to perform exercise training and attend at least 32 of the 40 sessions. Individuals were excluded if they had any medical condition preventing them from being able to exercise a moderate to vigorous intensity. So think about the ACSM screening algorithm here. And we also excluded them if they had hypertension, a diagnosis of type 2 diabetes, an autoimmune disease, were pregnant or anticipated being pregnant during the study. Now, we ultimately got 14 individuals into our study, 4 males, 10 females. They came in for pretest assessments. So pretest assessments, we took about a week to do a series of different tests, including health-related quality of life, resting heart rate, blood pressure, waist to hip ratio, fasting blood glucose, insulin resistance. And then on separate days, we also had them come in for a fasted resting energy expenditure assessment using a metabolic cart and in-body scan to determine percent body fat and percent skeletal muscle mass, as well as a separate 5-rep max assessment that looked at leg press, chest press, hex bar deadlift, and row. So after that week of pre-testing, individuals were randomized into one of our 2 groups, either cardio only or cardio and resistance training. And both groups came in to train 4 days a week for about an hour at a time. So looking at the exercise prescription, the big idea here is that both groups are coming to the gym 4 days a week for about an hour. That's something easy that somebody can implement into their life, and it's easy for the participants to plan for. As for determining intensity, we used RPE. So weeks 1 and 2, we got individuals familiar with the equipment, familiar with the 0 to 10 RPE scale. And then in weeks 3 to 10, we started adding in vigorous intensity exercise for both groups. The resistance training group always did their resistance training exercise first and then moved on to the cardio. At the end of the 10 weeks of training, everybody came back in for post-test assessments, and they did the exact same series of tests as at the beginning at the same time of day. Now we use SPSS for our statistical calculations. One-way ANOVAs were used to compare the groups at baseline, and then we compared within the groups using paired sample t-tests. Then finally, we calculated a change variable from pre to post for the groups, and then used a one-way ANOVA to determine if the groups were different from each other at the end. Here you can see our baseline characteristics for the groups. We had 9 individuals in both groups, and based on the p-values, you can see there was no statistical difference between the groups at baseline. Again, at the end of the study, we ran a one-way ANOVA on attendance, and there was no differences in attendance between the groups. Additionally, we had a 100% completion. So everybody in the study completed the at least 32 sessions required to be included in data analysis. Let's take a look at how our outcome variables changed from pre-test to post-test, and we'll start by focusing on blood pressure. So looking at the cardio-only group, systolic blood pressure went down from pre-test to post-test, as did diastolic blood pressure. However, only diastolic blood pressure reductions were statistically significant and also had a large effect size. Now, if we look at the cardio and resistance training group, we see something different happening. Again, both systolic and diastolic go down. However, this time it's the systolic blood pressure that's statistically significant and has a large effect size. Now, regarding our body weight, BMI, and percent body fat, the cardio-only group had statistically significant reductions from pre-test to post-test, and these were also a large effect size. In the cardio and resistance training group, these values were trending towards significance and had a moderate effect size. As for HOMA-IR, our value of insulin resistance, we did see that both groups had reductions. However, neither was statistically significant, although we were trending towards statistical significance with the cardio-only group. A similar idea here with the waist to hip ratio, where we saw reductions in waist to hip ratio, suggesting there was an improvement in health-related risk. However, these weren't statistically significant. Now, when we're comparing the groups, so comparing the change between the groups, the only variable that was different was strength. So the cardio and resistance training group had superior strength gains to the cardio only. So although the individuals in the cardio only group did have weight loss that was statistically significant, it wasn't really all that much, only a 3.6% reduction and a 2.6% reduction for the combined training group. Now, that being said, we did still see other benefits, including reductions in systolic and diastolic blood pressure. Interestingly, the cardio and resistance training group saw more improvements in systolic blood pressure, whereas the cardio-only group saw more in diastolic blood pressure. So this might suggest that there's some differences in the responses to the different modes of exercise, but more research would really need to be done to figure this out. Additionally, in our sample, we did see insulin resistance and waist to hip ratio improve for both groups, although it wasn't statistically significant. Part of this lack of statistical significance is related to the fact that our subjects didn't have extreme values at the onset, so they didn't have insulin resistance or high waist to hip ratios, so they had less area to improve. Overall, even though we didn't see significant weight loss, 10 weeks of either type of training appears to be beneficial for metabolic health in people with obesity. If you have any questions, you can contact me using the email below.